Okay, so welcome everyone to this Plain Film and CT webinar. My name is Saido and I'm the Customer Success Specialist at Collective Minds Radiology. Before we start anything, I would like to say a big Happy New Year to everyone. And I'm so glad that, we can spend this time together on this webinar, looking at some cases together with Dr. Lasker. It's just amazing, and I hope that, this first couple of days have been, treating you well. It has for me at least. That's very nice. With that being said, after the webinar or at the end of the webinar, I will send out the evaluation form. So make sure that you fill that out so we can send out the CPD certificate for you. And also, when Dr. Lasker are going through the cases, in the chat, there's two options. You can either send, the message to the panelists, or you can send it to everyone. I would suggest that you send it to everyone for your colleagues to see your answer. It might help them, in the way they're thinking and so on. So if you can, make sure that you send it to everyone and not only the panelists. I think that's it pretty much, but just make sure that, you follow along. You can do it on, Check the Minds if you have two screens and so on. But I will stop talking and let's see if Imran is here.
Hey everyone, nice to see everyone. Thank you for coming. We've got a few people still trickling in, which is great. So yeah, my name is Dr. Lasker. I am a consultant radiologist and I am going to be going through hopefully a few cases with you guys. I have prepared a few cases so that we can sort of hopefully do a bit of learning, and we try and keep it as sort of fun as possible, try and not make it such a formal thing. You guys can ask them any questions that you want. We've seen sometimes I don't get it 100% right, and that's pretty great fun as well. So do just feel free to get involved. It's kind of meant to be a little bit entertaining and a bit of a chilled out thing. So I'm going to share my screen now, and then if we could just make sure that everyone can see my screen. Can people just tell me if they can see it? Yes, no, maybe. Have we got anything? Sado, can you see the screen? Is it there? Yeah, great. Okay, awesome. It looks like we are live. So for those of you that don't know, Collective Minds Radiology, really great platform. It's really cool. They've got like a bit of a, you can add cases as groups, as collections and all that kind of thing, where you can go through the global community, go through cases. You should be able to find like a collection or a group that you're particularly interested in. So if you're, let's say, for example, interested in X-rays, there's like a reporting radiographer worldwide, particular area there. So there's a lot of like cool stuff going on. And obviously I've worked with Collective Minds for a while, and they've got really good visions for the future of the community of radiology. And I think it's a really good thing to get involved with, and it's free. It's free. So do check it out. Hopefully you got an account. You should be able to log in and then have a look at the cases at the same time as myself. So let's go through case number one. And the way I usually try and do things is that we have a look at it, we discuss it. If you see something abnormal, just throw it in the chat. And if you don't worry, I'm going to go through it anyway. So we have got what? We've got 1, 2, 3 views of what looks like the forearm. And actually, this is slightly more of the wrist, isn't it? And then this one is the forearm again, but a slightly more odd view. Right, okay, so then what we always do is we have to look at the forearm that themselves. And you can see that this is actually a very sort of straight looking radius. You notice the radius because it's quite big at the top here and gets a little bit sort of narrow at the sort of more proximal aspect. And the opposite is true for the ulnar. The ulnar is kind of big at the top here and then gets kind of small at the distal aspect. So that's just a silly way to try and remember which one you're looking at if you are at this point. If you're at this point or you are at this point. So then what you do is just try and make sure there's no sort of discrepancy, no linear deformity or any sort of buckle, tail, anything like that going along the actual bones. And the way you do that is really genuinely to zoom in and just follow along. And as you can see, the tools here are really, really great, just like having a normal DICOM viewer in your home. But this is all web-based as well, which is pretty awesome. And you can just follow along. So this area over here, normally, people, do call me up and say, look, what's going on here? But you have to also understand that there is something called an interosseous membrane, right? And then you do get attachments of some of the biceps tendon onto that. But actually, over time, over the tugging of the way the forearm is twisting and turning, you can actually get a little bit of calcification there. And that's actually completely normal. But as you come across to sort of this area over here, hopefully you can see that there is what looks like a bit of a buckling here. Can you see that? And a bit of an overlap of that radius, that radial head. And that radial head does look like it's still quite nicely aligned. And I don't know if people know this, but the way to actually make sure that the radiocapital alignment is correct is, so what people might do is to draw a line going along the shaft like this and say, you know what, this line going along the shaft of the radius is not going intersecting the middle third of the capitellum. That's actually the incorrect way to do it. You've got to do it along the lines of the neck of the radius here. And you can see the neck of the radius kind of goes at a slightly different angle from the shaft. And then neck goes this way. Now you can see that it does actually cross the capital, the middle third of the capitellum. So therefore, the alignment of the radius is actually okay. The radiocapital alignment is okay. There's no dislocation per se, but there is what looks like an impaction fracture over here. Now, on top of that, you can actually also see, if I just pan this across to this area, you hopefully can see that there is what looks like a bit of a joint effusion, and that you can see this kind of hyper dense, high density material sitting within this region, and there's a bit of elevation of this fat area over here. So an elevation, a bit of a fat pad. Now, yes, okay, fair enough. We don't usually talk about fat pads in the anterior elbow. Usually we're talking about fat pads in the posterior elbow. But in this particular situation, it's almost undeniable that there is some elevation of some fat, and there's some high density material located here. Now, the other thing to understand is that there is like a bit of a joint capsule like this. Now, if this joint capsule is for whatever reason ruptured, then you may not get this sort of hyperdense material located here, and you may not get this elevation of the fat pad here either, because the fluid is no longer kept within the capsule. It's actually flowing around over here, so you don't get that elevation. But in this particular situation, the capsule is actually still maintained, resulting in this sort of bowing of that fat. So you can see that kind of linear sail-like area over here. And that's happened because that capsule is still present, but there is definitely a fracture. So there's like extravasation of blood and a bit of fat all coming out of this radial neck. So this is a radial neck fracture. We don't usually stop because we should really look for any other fractures. And I don't know if you guys know this, but if you do get a fracture of the radius, sometimes you get a dislocation of the radial ulnar joint, but a little bit further along. And so in those situations, you'd be looking at something called a Galeazzi, which is like a type of fractured dislocations. You get a fracture of one and a dislocation of the other. And that's just something to look up. When it comes to forearms, you get something called a Morteggi or a Galeazzi. I can never say it, but it's Galeazzi or something like that. And that's the kind of that's the next thing to think about, because oftentimes people won't look for the second fracture and the next fracture. They get all happy about seeing that one thing. And then also on top of that, we do have a bit of a wrist image here. So you do have to kind of zoom in and make sure there's no distal radial fracture, because after all, the only way that fracture may have happened is because they've literally fallen on the hand. There's been a translation of forces through the forearm, hitting that radial head and resulting in that impaction fracture. And that can only happen if you've had this sort of impaction over here. So very, very important to have a look at the carpal bones. Sometimes you do have like a more of a DP view, just to make sure there's no fractures of any of the metacarpals or anything else on the scaphoid, and all that kind of thing is completely, you're hoping that's completely normal as well. But anyway, for this particular one, the only fracture really is this one. So hopefully we started off a little bit easy, but we will be, as we move on and we get through to some of the CT scans for definite, we should have some interesting cases coming up. So this one, pretty easy, right? One would hope. Hopefully everyone can see that. Please feel free to throw in what you think. But what we'll do, we'll have a look and just make sure that we can all see this fracture and we all have a system. So yes, we kind of go along like this, and the ulnar looks okay. One of the things to look for is the ulnar styloid. Often with any sort of radial impaction fracture, anything, you can get a radial ulnar styloid fracture, but that actually looks okay. And you can see that this is kind of a bit longer. This is longer than this, and usually they should really kind of meet with one another. So clearly there's been a bit of loss of sort of bone in this area, and therefore that would be what was called a positive ulnar variance. If this is shorter, that's called a negative ulnar variance, and that can actually be just the way the person is. And when it's just the way that person is, let's say they've got something called a negative ulnar variance, that can actually predispose to carpal bone abnormalities, such as you get avascular necrosis, something called Kienbock's disease. And one of the predisposing factors can be negative ulnar variance. But this positive ulnar variance is actually as a traumatic fracture of the distal radius. You can see that distal radius fracture over there. And you can say, okay, well, I'm done now. But actually, because we're all radiologists for the time being, we do have to look a little bit further. We do have to make sure there's no other fracture anywhere else. And so you got to have a look at that sort of the articular surface and see whether there's any articular involvement. And it does feel like there is a bit of a radiopaque / radiolucency going this way, all the way along like this. And there's a bit of impaction as well. So I would, be pretty sure that there is some involvement of the articular surface on this particular X-ray. Then on top of that, you do want to make sure that you haven't looked at the scaphoid. Sometimes you get scaphoid fractures, but this scaphoid looks okay. No waist, no proximal or distal pole fracture. And then you got to make sure that this is not too wide either. Otherwise, you're looking at scapholunate ligament injury. And then, of course, you want to be looking at the rest of the carpal bones and the metacarpals as well. Incidentally, can you see how this looks slightly more sclerotic along here, a little bit more sclerotic along here? This is also looks a little bit more sclerotic and a little bit more sclerotic. So therefore, this would be in keeping with osteoarthritis at both the first carpal metacarpal and at the STTJ. So that's the scaphoid trapezium. Oh, I can't remember what it's like, the STTJ. So anything beneath here, this is where you get the more increased sclerosis and therefore osteoarthritis. And very, very common areas to get osteoarthritis. So even if everything is normal, most of the time you see osteoarthritis in those particular areas as well. And then we just check this area as well, just to make sure there's no other fractures. Here you can see, this is sometimes the only view you get in exam cases anyway. You do want to follow the line all the way along, all the way along, all the way along, and just see where it leads to, see whether you can see the fracture. And on this one, I feel like that cortex that I've just drawn out is probably not the radius, it's actually probably the ulnar. But you can see that this cortex here is completely disrupted over here. So therefore that must be the sort of radial shaft over there. So that is a distal radial fracture. Feel free to throw in some answers if you want. That'd be great. Just to see that people are actually awake. How are we doing? How many people are here? Good. We've got a fair few number of people, so hopefully get a little bit of interaction, especially when it comes to the CT scans. I'm looking forward to going through those. So, okay, this one, please feel free to tell me what you think. Anyone's got any answers? Anything coming? Going to just zoom around. Yeah, good. Someone's given a few answers here. That's good. Love it. So yeah, the way to do this. So what I always say whenever you're looking at a hand is to always have a look at the fourth and fifth metacarpals. Very, very important, because that's usually where you get fractures. Normally you get fractures around here because the way people punch, well, they say they don't punch, but they actually do. They don't punch correctly if there is a correct way to punch, and the forces that can actually come from here ends up kind of going this way rather than going this way. And then you end up getting fractures here, fractures here, fractures here. But yeah, people have quite rightly seen that's not the actual fracture at all. Well, genuinely, when I'm looking at X-ray, that is the first place I look. First place I look is there. Next place I look is there. And then I look at everything else. Then I genuinely go through every single bone, all the way along, all the way along. Some clues sometimes can be that this area over here, this thenar eminence, that's a good place to look just in case there's increased soft tissue swelling. I've seen massive amounts of soft tissue swelling, which has alerted me to a possible fracture, and then ended up finding a fracture there. So just be aware that soft tissue can be a really big key to looking for fractures. But again, we're just going to be looking through here, and we can see, we just follow along. That looks okay. 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 But when you get to this terminal tuft here, can you see that radiolucency there? And there's a little bit of, there's what looks like cortical reaction as well. So that this is probably not like the newest fracture ever. They probably just had some really bad pain, left a few days, and then finally come to see someone. And you can see, yep, there's a radiolucency there. And it does look like it's maybe slightly impacted. And yep, there's a fracture. It's most likely to be like, I think this person was actually using a hammer, and they hammered their finger and ended up with that particular injury. So not very nice, is it? But anyway, we still got to keep looking, making sure there's no fracture. Some people go, oh, is that a little fracture there? Not, I wouldn't think so, because it's kind of got a very corticated area around it. Looks very, very sclerotic, which would most likely mean it is actually a vessel in this area, in the same way that this is. Can you see that there's a radiolucency here and some increased sclerosis along the lines of it as well? So that's been there for a very long time, similar to that area there. So we're probably not going to be calling a fracture along those areas over there. And keep coming down, and just make sure that all the bones are fine. And this is genuinely what you do when you're looking at these x-rays, you just got to make sure that there is no evidence of any other fractures, because like I keep saying, and I've always said on all these talks, is that the second fracture is usually the fracture that gets missed the most. And on the subject of soft tissue, can you see how swollen this poor person's how swollen this poor person's terminal phalanx is? You can see, like, this is the line it should go, and you probably should be thinking of it going something along like this, right? But it's just not. It's all kind of coming out this way. You can see it looks a bit heterogeneous. Nail avulsion, yeah, you're right. Look, can you see that? It looks like the nail is there, and there's a little bit of air located in a few tiny locules over here. I mean, tiny little speckled calcifications along there. So what might have happened is actually they might have hit the hammer that way, and all the force went that way. Can you see that? And that's kind of caused that fracture and that nail to come off. So yeah, good pickup. That does look like there's been a bit of an avulsion of that nail. So not a nice injury, is it? Quite horrible. Okay, let's have a look at this one. This is a chest x-ray. Hopefully it will turn up. Yeah, a chest x-ray of someone who is short of breath. So obviously when you're looking at x-rays, especially in an emergency environment, you got to be thinking about the first things first, right? Pneumothorax. Is there pneumothorax? Is there a broken rib? You know, is there air under the diaphragms? Those kind of things. Those are the big questions you want to ask yourself straight away, right? Straight away, those are the questions. And then you move on to everything else. Then you start thinking about everything else. So in this particular situation, do have a pneumothorax. Doesn't look like it. It looks like all the airways, all that line, all those linear lines going all the way to the edges, all the way to the edges, all the way like so. So we're not looking at what looks like, it doesn't look like a pneumothorax. And the other way to do, the one thing I'd always say is genuinely when I'm looking at x-rays in the first instance, I do look at the apices to make sure that I can't see like a linear line going along like this to suggest there's like a really small apical pneumothorax. And I've seen a few of those get missed just because they're really, really small. So very, very important. So yeah, some really great answers coming in already. So you can see here that, you know, the hilar, where are the hilar? So the hilar should really be around here, shouldn't they, in your average person? But these look like they've gone upwards. Okay, so that's a bit of a clue. And someone said it perfectly well. So look at that hemidiaphragm. Yeah, that's all the way straight like so. But this one kind of tents upwards. Can you see that? It's like a little tent. So something's saying to us that everything's kind of being pulled upwards like this. And there's a bit of a tenting of that hemidiaphragm there. And therefore, when you come back to the apices, you can see that there is scarring over here as well. Can you see that? So therefore, and then you can see a bit more scarring over this region, a bit more scarring over this region. So someone has said quite correctly that there looks like apical fibrotic changes and tenting of the left hemidiaphragm. And the thing is, like, there's actually quite a few different diagnoses for you know, apical fibrosis. TB can be one of them. One that could be sarcoidosis. Yeah, exactly. It could be massive fibrosis as well. It could be because of exposure to like berylosis and that kind of thing as well. So it's just important to know that, yeah, you could say TB, but this patient's got shortness of breath and it looks like apical fibrosis, which can be as a result of multiple things. Now, when it comes to TB and sarcoidosis, one of the things to also look for are lymph nodes, because mainly with sarcoidosis, but it can happen with TB, you can get calcifications of the lymph nodes. If you're looking in these areas, and these areas over here, in the paramediastinal areas over here, because when you've got calcified lymph nodes, this picture, then you'd be saying something like, oh, I think this could be sarcoidosis. If you've got what looks like a bit of a cavity, which this arguably could be, then you could say this could be tuberculosis, correlation with clinical history. And yes, on this particular occasion, I think you can comment on the trachea, because you can see, yes, fine, fair enough. Like, I'll just say this for the people that don't know, you do look at the medial ends of the clavicle for alignment, right? So medial end of the clavicle is there and there. So clavicle, and then you look at the spinous process, but actually that spinous process looks like it's kind of that way. So it means that this is slightly rotated, so therefore you might say, well, you know, I can't tell whether that is a deviated trachea, but just look at the contour of the trachea. The trachea should really be straight, shouldn't it? But this sort of veers off. I mean, that's a big exaggeration, but this kind of veers off that way and then carries on down, right? And coupled with everything else that we've seen in terms of the tenting of the hemidiaphragm, the more predominance of the apical fibrosis, then yeah, you could say that there is also deviation of the trachea based on the images that you're seeing. It's not obviously on fast, but you could say within the limitations of the rotation, I am concerned that there's also tracheal deviation as a result of the more extensive right apical scarring or fibrosis. So, I mean, this is not an acute study, but probably something that you don't want to ignore, especially if someone comes in shortness of breath. And sometimes this is the first time they've turned up, and now they're going to have to end up going to the respiratory team, be put on medications, look into the clinical history as to why they've ended up having this particular situation for them. Okay, so let's have a look at the, so thank you for commenting and getting involved in that. That's really useful, actually. Okay, so let's have a look at this x-ray. So this patient has got some pain. And if I said it was in the anatomical snuff box, does that make sense? Does that kind of give everyone a clue? So again, so what we'll do, we kind of, what I always do, genuinely is what I always do. You go along like this, and I always just follow the radius, yeah? Follow the radius, make sure that's okay. Follow the ulnar, make sure there's no ulnar styloid fracture. Can you see how this is slightly out of line with one another? So you could arguably say there's a bit of negative ulnar variance. The lunate looks okay, so there's no evidence of any avascular necrosis at all on this study. So that's all good. People have come out with the answer, which is great. Thank you. And then, yeah, you're right. So look at the lunate, that looks okay. And then can you see that scaphoid like this? And then there's like a bit of a step deformity there, possibly a second step deformity there. And then the scaphoid continues on like so. So you can see that this is what looks like a scaphoid fracture. And so then you've got to be, you do have to look at it a little bit closely. And you can see it looks slightly sclerotic in that area. So maybe it's been around for a little bit longer. And so you do end up worrying that maybe this patient's got something like developing a vascular necrosis. And so you'd actually end up looking into clinical history, see when the injury actually has happened, and correlate with, is it possible that this is just sclerosis? But yeah, I mean, this could just be sort of a bit of healing, a bit of cortication, trying to heal that up rather than avascular necrosis, but probably worth following up just on the off chance that it is going to end up becoming avascular necrosis. And that's what often happens with these patients who've got scaphoid injuries. You end up trying to follow them up. And I don't know if you guys, well, we used to do this a fair bit, but sometimes they'd continue to have pain. You do the x-ray and this never seems to heal up. And you don't know whether it's like it's actually healed up at all, where there's been a union, which is either going to be like an osseous union or a fibrous union. And the only way to really be 100% sure is to, well, I don't know is that only way, but what we used to do is inject contrast into that sort of radiocarpal area. And if contrast ends up seeping through into here and into here and into the rest of the carpal bones, then you know that this fracture is not healed. But sometimes you'd inject contrast into here and there'll be no contrast going anywhere else, suggesting that although that does look like there's still a fracture, it's probably going to be a fibrous healing or a very slow healing, but there's no communication between this and the rest of the carpal bones. So just like, I don't know if people do that, but we used to do that a fair bit, but I don't seem to get that on my list these days anymore. But we used to inject it in ultrasound actually, and then they used to go to the CT scan and they get scanned. Right. Fine. So we have got on to CT scans. CT, awesome. I love CTs. So my advice to anyone that's not used the platform before is when you do open it, there is something called thick. So you can do thick or you can do thin. I think on this particular one, let's go for thin for me. And then you click on this little cloud arrow and wait for it to download. You can see that red line going all the way across. That should go all the way across to the very end. And then that will mean that it can actually scroll through really smoothly. So I would really, really like people, if possible, to just have a look at it and just quickly scroll through and just say what you think it is. Just give me a guess. It doesn't have to be right. It doesn't matter. We're all friends here. Nothing to stress about at all. Okay. So then what I'll do, I'm going to start working through it slowly. So I kind of work through a system showing you how you'd go through this as a system and hopefully get to the same answer that you get to. But I would really love to see what people think. So first off, we can see that this is a CT abdomen and pelvis. We do have some of the lung, which is fairly common, but actually we've got quite a lot of the lung on this one, don't we? We've got all the way up to sort of almost mid-chest level, kind of unusual. Not sure why that's happened, even though it's an abdo-pelvis. So then you come up to, the areas that could be causing pain. So in a systematic manner, when you've got an adult patient, any patient with pain, the way to look, you have to think about, okay, what could cause pain in any sort of human being in the abdomen? So generally speaking, it's going to be the gallbladder. The gallbladder could cause pain. So we'll have a look at that gallbladder and you can see, oh, hang on, there are a few stones sitting within the gallbladder. So that could be it. This could be the answer, right? This could be a cholecystitis. It could be a biliary tract obstruction. But actually, when you look at the biliary tract, so what you look at the portal veins, and next to it, you can see the sort of radiolucency, right? So that radiolucency there is more likely to be the biliary tract, but it doesn't look particularly large at all. So we're not really looking at sort of intrahepatic duct dilatation. And when you're looking at that CBD, the CBD looks the gallbladder looks very, very thin. So it doesn't look like it's particularly thick. It doesn't look like it's hyper enhancing. And around it, there's not very much in the way of fat stranding. So I don't think we can go for being the gallbladder being the cause of the patient's pain. The next thing we can do is have a look at the pancreas. So the pancreas is kind of leaf looking thing going all the way like so. And this pancreas looks kind of thin, actually, very, very slim. Doesn't look like there's any masses. And more importantly, around it, there's no fat stranding whatsoever. Okay, so we're not looking at any we're not looking at any pancreatitis here either. So that could be another cause to someone's abdominal pain. The next cause for abdominal pain could be obstruction of the kidneys. So we're looking at the kidneys here, and you can see that actually they've still got a bit of fatty hilum in both, so they don't look like they're kind of backed up. And actually the ureters look very, very thin going this way and this way. So that's the ureter there, and that's the ureter there. They look very, very thin. Incidentally, there are a couple of simple cysts here, but again, nothing to worry about. Cysts don't cause pain. So we're still thinking, okay, what could be causing this patient's pain? So the next thing to do, which is slightly tedious on some levels, but once you get good at it, you can literally kind of do this and find it. But what you have to do now is follow the bowel, right? So someone has said that they've spotted something in the rectum. So yeah, there is a bit of fat infiltration within the rectum, but that can happen with age, and that can actually happen with some people can have repeated inflammations of the rectum, the bowel wall, which can then result in the sort of fatty infiltration, the sort of fatty appearance to the rectal wall. So that can actually be quite normal. So what we can do, but that's not going to be like an acute problem. That's not going to be the reason why someone's coming in with such acute pain. So then you can see here, we're going to follow along, got a bit of feces going along there like this way, going along like so. It doesn't look like there's any sort of inflammation. So all the fat, there's no fat stranding. We're coming up this way, this way, this way. Can everyone see that? Hopefully you can follow with me. Follow along. Any more answers? No answers yet. So we're coming up to here. Where are we? Let's get the no, let's get scroll to make it slightly easier for me. So going this way, you can see that's more colon that way, but it kind of veers off, doesn't it? Where does it go? It goes this way, I think. Back that way, then it goes across this way, and then upwards, doesn't it? Yeah, upwards. So if you're ever lost on a CT scan, try and use the constants, the descending and the ascending column. Ascending will be here, descending will somewhere here. So I reckon this is the ascending colon along this way. I think this is going to be the one coming up this way. Oh, look, and we join up here in the region of the splenic flexure, and it seems to kind of dip down again. Can everyone see that? Dipping down. Okay, so we're curling back up again. So quite unusual for the descending colon to do that. But anyway, we're here now all together. Coming up here to the splenic flexure, coming up to, where's the spleen? Okay, we're almost there. Okay, we're here. Can everyone see that? Hopefully people haven't fallen asleep. Okay, you can see, but actually there's a bit of fat strand around here. Can you see that kind of liquid sitting around this area? So, but you know what? The actual colon still looks okay, but there's a bit of fluid around the spleen. Can you see that? So something's up. So this person's not come in for no reason. We're following along this way, and that transverse colon does look a little bit collapsed, but we're following along, follow my mouse, going this way. We're coming up to, well, it should really be the ascending colon, but we're quite mid-abdomen now, aren't we? Should really be over there. We come up to this point, it looks like it's slightly dilated and a bit difficult to follow, isn't it? It just seems to sort of become what? Small bowel located within the area. So let's come back up. We'll come this way. I reckon we're going that way. Maybe that way, is it? Coming up that way. Very odd looking bowel, isn't it? Someone said stomach. Okay, yeah, good. That's a good call, good shout. So coming back this way. So we came up that way, Now we've got to try and figure out where we go from here. I feel like we go this way, don't we? What are people thinking? Down this way, down this way. Can we get down here now? Hope we're not following small bowel all the way along. Okay, now we've come up to here. And look, can you see that? Can everyone see that? So we followed that descending colon that way. You've got a bit of what looks like fat density there. And then you kind of seem to sort of go into this area here. And then it becomes really dilated. Can you see that? Can I convince people of that to be true? So generally speaking, I would say that this area, if you got like fat within the ascending colon, like in such a focal way, you're probably looking at the terminal ileum somewhere there. So we're kind of in the region of the, it looks like we're in the region of the ascending colon, but there's a weird sort of like stricture or something. Yeah, someone said stricture, which is not a bad shout for what's going on here. It does look like it kind of comes up this way and then twists along this way. So then this, what I thought initially could be the stomach, but actually if that's not, this thing is not the stomach, what could it be? So where is the stomach then? So that's not the stomach. We'll come up to, where is the stomach? So the best way to find the stomach is to go from the esophagus. So esophagus, stomach is there. So, okay, this is not the stomach at all. This is a very, very large piece of what looks like bowel and what looks like a bit of a twist or like a bit of a stenotic area located somewhere within this region, right? And it seems to kind of communicate with the ascending colon. And so someone has come out with it, which is really good actually. So what we'll do, sometimes the best way to find these things is to go on this coronal view. And you can see what we thought was a stomach initially, but actually it's not the stomach at all. And people have really gone for it now, which is really great news to see. But yeah, you're completely right. People have said, is this a cecal volvulus? And that's exactly what this is. This is a cecal volvulus. And so what's ended up happening, can you see here? That's a twist. So there's almost like a whirlpool thing going on somewhere around here, twisting into here, and then going into that. So that's the cecal pole, twisting like that. So then what's that over there? That looks like this could be probably terminalium or distal ileum. So this is not stomach. This is a twisted cecal pole. And the next thing you know, now you know that this is a cecal volvulus because we've got that twisting whirlpool sign going on over there. Therefore, this is cecal volvulus. Then you've got to think, okay, next thing to think about, is there a perforation? Is there ischemia? Now, you may say, look, there is no ischemia at all, all right? I mean, there's no ischemia and there's no perforation. But have you noticed how hyper-enhancing that cecal pole is compared to everywhere else? Look at that compared to that bowel or there, that bowel there, that bowel there. Very, very hyper-enhancing. So what can happen is that before the cecal pole becomes compromised, it starts to get a bit more, like the blood flow doesn't go as well because it's sort of so edematous. And so I think what happens is that like it starts to hyper enhance and then it may end up having a perforation or it may end up having ischemia. So this is a cecal pole. And I think that this is starting to get compromised because of how much pressure is being involved here. And therefore is a surgical emergency. So you can see how using sort of these principles, you go, okay, gallbladder, is it the pancreas? Is it the kidneys? Is it the is it the kidneys that's causing the pain? If there's none of those things, you want to see on coronal again. So what I'll do, I'll go back onto here, coronal. So this is the big viscus that we had, yeah, and we thought that was the stomach, right? And then as we kind of come to the bottom end here, can you see, I'll zoom in. Can you see that around this point here, where it almost feels like a stomach pylorus, there's a bit of a twist here, a little bit of a twist. And then it continues into that bowel. So we were seeing that on the axial view, but now we can see on the coronal view that, look, bowel comes this way, it twists around like this, like a circle, and then into here. And so most likely, all this stuff over here, all that stuff is probably going to be sort of dilated small bowel or distal ileum rather than anything else. Hopefully that makes sense. Okay. So anyway, that's a cecal volvulus, and as good a case as I have found over the many years I've been reporting. Genuinely one of the best cases, and now you've seen it too. So hopefully we've all learned something. Right. So let's go for this case. This looks like a non-contrast study, and we can see that this patient is lying on their front because that's where the table is. So when you've got a non-contrast study and the patient is lying on their front, therefore this must be a CTKUB. So we are looking for renal stones. So this must mean this patient's got, I guess, what, left loin to groin pain or right loin to groin pain. We don't know just yet. Well, I do know, but I'm not going to tell you. So then we're going to turn this round. It's just the easier way to do things because your mind kind of gets used to the way things are in the human body in a specific kind of position. I mean, you do have a bit of internal NPR, but not good enough to really just find the problems initially. And then, oh yeah, I've got to do the cloud just to make things a little bit easier. So again, yeah, feel free to go through this case and tell me what you think. I really enjoyed seeing some of the answers. Adhesion is not a bad shout, but there's no history of previous surgery on that last one. Stricture ileitis was a good shout as well in that last case. Again, no, but there wasn't really much in the way of inflammation, and hopefully on the coronal views, you can definitely see how it twisted. There was definitely volvulus. Okay, well, let's go back to the bottom of the chat. Okay, so no new questions coming up. Let's go from the top here. Non-contrast scan, you can see there's no contrast. Again, gallbladder looks okay. You know, can you see there's a bit of a slight radiolucency sitting within that gallbladder? So sometimes you get cholesterol heavy stones and they will look very hypodense. So I would not be surprised if this patient's got a few tiny calculi that we can't see because they're not radiopaque. Again, pancreas, what does the pancreas look like? Pancreas looks okay, going along like so, no inflammation there. And then the reason we did this is because we're thinking this patient's got a renal stone. But can you see, you know, actually, it can't really be a renal stone because, well, we don't think it's renal stone, could be, but there's no renal tract obstruction because there's still fatty hyaline bilaterally. So there's no backing up of any of the, there's no backing up of the renal tract. But can you see here, that is going to be the ureter there, that little dot, and you've got to follow it. And on genuinely, after kind of a bit of practice, you can sort of anticipate where that renal tract will go, and you can see going all the way into there. See that? So that's a vesico-ureteric junction. That's not a calculus. So this side, let's have a look. It's actually sometimes better to go from the vesico-ureteric junction rather than the other way. But you can see it turning up this way, and you come up here and you think, oh, is that a stone? That one there. But actually, look, that's a ureter, and that goes down that way. So that can't be a stone. That must be a phlebolith. So that's one way to figure out whether it's phlebolith or not. Just see whether it falls in line with the ureter. That's ureter there, ureter there. Just keep coming, ureter there, ureter there, I think. Probably keep coming up. And I think probably it's veered off. So I haven't followed the proximal ureter as well as I could have. So I'm going to try that again. You can see ureter, 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 down this way. There we go. Now that makes more sense. And there's no stone whatsoever in this patient who's got this, this pain. So someone has said, this patient's got a hip replacement. You are correct. There is a hip replacement. And can that be causing pain? Yeah, it could do. But in this particular situation, it's not. The way to do it is also to have a look at the bone windows, just to try and make sure there's nothing grossly abnormal. Sometimes you can get a fluid collection, which is like a pseudo, you can get something called a pseudotumor. You can get little bursts and pockets of fluid as well, which is to do with like the metal ions reacting and resulting in collections there. So good thing to look for, but that's not what's going on here. So we're going to do the tedious thing again. We have to go through the bowel. So you kind of follow up this way, coming up this way, coming up this way, follow along. We haven't seen any inflamed sigmoid colon, but the sigmoid colon does go quite far up, doesn't it? Coming up this way, and I don't know, has someone noticed it yet? Someone may have noticed, but I just want to make sure we're good at following the bowel. Going along like this, that's still sigmoid colon, veering off all over the place, going this way. Then we're coming up to the descending colon. It all looks okay so far. Then we're coming to the splenic flexure, coming along that way, going this way, across the transverse colon, going down this way to the ascending colon. And can you see the appendix just sitting there, a little tiny tubular thing going this way? Let's just try and draw that out. It goes like this and goes like this. Yeah, so that's all good so far. So a few people have given the answers. Let's come up this way. And someone has spotted, and maybe they've seen this case before, I don't know, but we can see. Can you see that circular thing there? See that? That is, well done. So then you can see there's a circle there, can't you, right? That doesn't look usual. Where does that? So is that a lymph node? It doesn't really look like a lymph node. It doesn't have that sort of fatty hyaline. And it doesn't really kind of conform to, like, normally you get lymph nodes along where the vessels are, but this is not. This is probably on the outside of the sigmoid colon, the outer side. So you're probably looking at the anti-mesenteric side. So if it's on the anti-mesenteric side and you've got this hyperdense lesion with a spherical hyperdense lesion with a kind of more radiolucent center, this is more likely to be in keeping with, exactly right, epiploic appendicitis. Epiploic appendicitis, slightly unusual place to have it, only because the sigmoid colon can be so mobile. But if that was anywhere else in the place that you'd normally expect the sigmoid colon to be, you would say that that is epiploic appendicitis. And examiners and all those kind of people, they love this kind of case because it's like an atypical presentation of a very typical finding. This is a epiploic, no doubt about it. It's just slightly unusual in that it's so high up in the abdomen. But this can happen a lot where someone comes in with query renal calculi and all that kind of thing, and end up having appendicitis, diverticulitis, and epiploic appendicitis. And just in case people don't know, treatment of this is nothing. Rest, just relax. Don't stress. That's what it is. That's the treatment for this. Right. So we've done that one. And now we're on to a head. So we are going to do a CT head. This is a youngish looking patient. If you can see any abnormalities, do let me know. What I'll do this time is just download the entire stack, and I'm going to go for the thick slices. Feel free to go for the thinner slices, thick slices if you want. So the way we teach this on our course, a course called the CT head course, which we'll be running this way, by the way, this year, acute CT head course, as you look for the CSF spaces, that's one of the first things you do, and you work from the top and work your way all the way to the bottom and make sure that you've had a good look around. So the CSF spaces, for those that don't know, are here, 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 here. So all this kind of black, kind of not so dense areas of CSF spaces. And you can see actually they all look very nice and thin and linear all the way along. Coming further down, everything looks okay. You're not particularly worried. You can't really see any gross abnormalities with regards to any crowding or effacement of the CSF spaces. The last thing I do these days actually is, because I have been caught out, look at the foramen magnum and also look at the cerebellar tonsils and see whether there's any tonsillar herniation. Nothing like that here. This all looks okay. So you may be forgiven to say that this is a normal scan. This is not a normal scan at all. It's not a normal scan. Can anyone tell me what they think it is? If I gave you a clue that they came in with left side of weakness. So then what we could do is there should be a stroke window. Let's see what stroke. Now, I'm not really keen on that stroke window. It's a bit too, yeah, I'm not sure about that one. So let's try and go like this. So we can see the reason I've done that is that I want to see the gray-white matter differentiation. So if we're saying this patient got left-sided weakness and we're looking for a right-sided problem, and coming further down, around this area over here, once you've done that sort of gray-white matter differentiation thing where I was doing, like we kind of just doing this, can you see that there is actually a difference in the gray-white matter differentiation? Okay, just in case someone doesn't know what I mean, this is gray matter and that's white matter. And what you should be able to see is a nice difference between the two, particularly on this particular window that I put onto. The kind of freestyle there, haven't I? But can you see here, gray, white, gray, white, gray, white? Not so gray, white, not so gray, white there. Can you see this whole area looks a little bit less gray, white? You can't really see the gray matter so well. And actually, when you come to this point, if we reset all, come down to this area, can you see, I'm going to put a little arrow. Can you see that little dot? So that's in the Sylvian fission. There's a little dot there, but there's no dot there. So this is called an MCA dot sign. That's actually a thrombus. And you can see that's resulting in that very sort of almost quite subtle appearance of an early infarct. This is an early infarct secondary to a very small thrombus. And so sometimes, you know, this is so hard to see. I mean, that's the thing, like what happens when you got an initial infarct, like a hyperacute infarct, you don't get much in the way of gray-white matter changes at all because it happened too early. But then you start to get subtle gray-white matter loss and eventually have the more stonking gray-white matter loss that maybe I'll show you guys later. And that's why even if you've got someone who's got left-sided weakness, you may end up doing thrombolysis anyway, because it may be too early for you to see the thrombus or any of the sequelae of a thrombus being there. And then the thing is, like, the only reason you're actually doing a CT scan, if someone is convinced that this person's genuinely having a stroke, is to make sure that it's not too big a stroke. Because if it's too big a stroke, i.e. multiple territorial areas of the brain that's been involved, then you can thrombolize a patient. But if there's like massive sections of thrombosis where there's loss of gray white matter differentiation, then the risk of giving thrombolysis can actually increase the risk of them having a subsequent bleed. And also, you also want to make sure that you're not looking at a hemorrhagic bleed in the first place, because if you're looking at hemorrhagic bleed and you go give thrombolysis, you're going to end up causing even worse bleed. But anyway, this is an MCA dot sign, almost classical case. I've seen better versions, but hopefully you can appreciate that by changing the windowing, you can get like you're giving yourself a better chance of spotting the abnormality rather than just flicking through and hoping you see something. Right, so I'm not entirely sure what this case was. Let's download the image. Oops, what have I done? So let's reset all. Reset all. Okay, so let's scroll. So generally it's probably going to be abdominal pain, isn't it? Go all the way to the top. So it looks like a non-contrast study, this one. And so we just do the usual things, try and make sure that we have looked around. So the gallbladder looks okay, doesn't look like there's much in the way of fat stranding. Let's have a look at the pancreas. Pancreas sitting over here, okay, and that looks okay. Doesn't look like there's any fat stranding there at all. So that's good. And then the kidneys, let's have a look at the kidneys. I mean, non-contrast, sometimes you get people who do a non-contrast scan of the patient and they're like lying on their back. I've been on one trust where they've done that. And then you come down, follow that ureter, follow that ureter, follow that ureter, all the way. And actually that looks okay, doesn't it? So that ureter looks okay. Bit difficult to see this ureter. Actually, yeah, that ureter's there, isn't it? Follow that up. And there was a bit of a calcification there, but it looks very, very punctate. So less likely to be a calculus, but let's follow all the way from the top now. Let's go this way. Where is that ureter? Where's that ureter? There. There's the ureter. Follow down, follow down, follow down, follow down. Keep following, keep following, keep following. Yeah, that ureter there. So you can see that calcification there. That's not going to be a calculus. That's going to be some vascular calcification. Keep coming this way. Oh, some more vascular calcification. Don't go for fool's gold. Can't really quite see the ureter anymore. Very difficult to see, isn't it? Around there. But it must be this one coming this way. So therefore, okay, so is that a stone? No, this is the ureter over here. Herniation. Yeah, perfect. Good. Okay, so fine. So that looks like we don't have a kidney stone. We don't have anything like that going on. So that's good news. So let's look at the bowel. Follow our way up. So bowel is here. Follow along like so. Follow my mouse. Follow my mouse. Where are we? Sigmoid colon that way. Oh, sigmoid colon veers off this way. Okay, goes this way, all the way this way. Still looks okay. No, not much in the way of inflammation. Now we come to one of the constants. We can see the constant is going to be this guy over here, which is going to be the descending colon, coming all the way to the top. We come to the splenic flexure, coming hopefully to the splenic flexure, and then going across to the transverse colon, all the way across like so. Transverse colon looks okay. Does everyone notice that actually there's a hernia there, isn't there? But a bit of fat going through, but that doesn't look like there's any herniation of bowel so far. We'll come back to that. That looks okay. And then we're coming up to what will hopefully be the hepatic flexure at some point in life, probably somewhere here. Okay, then we're coming all the way down. Then what's going on? Okay, so we come to the ascending colon. We'll come this way. What's going on? Okay, we seem to come back up. Okay, so are we at the cecal pole yet? Difficult to know. We come back here. So that might be the cecal. That might be the terminal ileum over there. And then that's the distal bone. You can see that kind of herniates through that way, doesn't it? So there looks like a bit of a hernia there as well. And it does look like maybe a little bit inflamed, doesn't it? But a bit of an odd way for this bowel to go. But actually, there's also a bit of bowel. Can you see that? That's going this way, following this way, following this way, going that way, and then just disappearing, you see? So this particular situation, you can see this appendix looks kind of long and a little bit larger, and there's and you follow that fat strand, there's a bit of, if you look at the fat around here then compare it to around this area, it feels like it's more focalized towards that appendix rather than anything else. So yes, you do have a hernia, but there's not much in the way of fat strandings. It just seems like there's a bit of crowding. And if it was incarcerated, then you'd expect there to be like small bowel obstruction that way or that way, but there isn't really much in the way of compromise of that small bowel there. What you actually have is what looks like inflammation of the appendix and inflammation and slightly thickening of the appendix. So actually, you want to play that. If I would probably say there's more likely to be an appendicitis. And the thing is, they've got these hernias here and that hernia down there, probably because they've had previous surgery. It's probably going to be, keyhole surgery of some sort. But and probably because of this hernia, look, they've had a previous hernia in the past. You can see like all these clips from the anterior body, and that's actually probably a mesh. Can you see that? So you've got diverification of the rectus muscles in this kind of sheet going along like so, and these sort of surgical clips over there. So they've had previous surgery, but this is actually, I think, going to be an appendicitis rather than anything else. Okay, so we have got to the end. Do we have time for one more? 10 minutes. We have what? Do you want to do one more? Can we get yes, no, maybe, probably not? Yeah, okay, fine. So it looks like Saidul has given me a case to look at. Have a look. So let's open this one. Oh, we're going to put this one in. Okay, fine. If this is the one I think it is. Okay, fine. Let's put this through. So I'm just going to download it. It's coming up. Wait for that red line to go all the way across. So first off, we can see that this is a contrast enhanced study, right? I think, yeah, I know this one. Okay, fine. So we're going down this way. So this is a contrast enhanced study. Looks like we've got what? We've got arterial phase and a portovenous phase. We've done 2 phases for some reason. The reason why you do 2 phases, generally speaking, is if someone is bleeding, you're worried about active bleeding somewhere. And usually you do that sort of in a stabbing sort of situation. So this patient, straight away, we can see that the lungs have got, let's try and get the lung windows. Where are the lung windows? 1, 2, 3, 4, 5, 6, 7. Yeah, 7. So they do look like they've got extensive scarring of both apices. You've got a bit of bronchiectasis here, multiple reticular, these lines over here. Again, some bronchiectasis, probably some long-term lung changes. And coming further down, that mediastinum looks okay. We didn't see a pneumothorax, did we, on this patient? So that's good news. They should be fine. They've had some previous surgery, haven't they? Look, you see multiple surgical clips sitting within their sternum. And they've got these, what looks like maybe some stents, probably some cabbage, probably had a cabbage or something at some point. So anyway, those cabbages look okay, don't they? So you can see there's a bit of air located within the region of the ventricle over there. That can be normal because when you're injecting contrast, sometimes some air goes into the heart and into the vessels. You sometimes get a bit of air there as well. So nothing too bad to worry about. Does this look normal to you guys? Does it look normal? Okay, so bowel looks okay. Well, I haven't done the bowel. Liver looks okay. Gallbladder looks okay. Adrenals look okay. That spleen doesn't look quite right, does it? Can you see that spleen over there? And there's this high density material sitting over here. So they're bleeding. And there's a sort of low density stuff over here. So you are worried that, this patient's had some sort of bleed somewhere. Have they had a laceration of the spleen? Have they been stabbed somewhere this way? So you're looking for stab wounds that way. Can't really see much. I mean, how else could they have a low density area over there? So, I mean, it's possible, but I just can't see where that stab wound would have happened. Bowel-wise, bowel looks okay. Let's go up this way. Let's follow along. Some diverticulosis, but no diverticulitis. Coming up this way, coming up, all the way across. We're going okay still. Bowel looks okay. Doesn't look like there's any laceration, perforation, or anything like that. So, and then you've got a periumbilical hernia, don't you? Okay, so not really seeing much at the moment. So then you've got to look for, we'll probably think it's a stab wound of some sort. So you look at the subcutaneous tissues. Is any stab wound there at all? Okay, that looks like, okay, that's just the sort of the breast tissue area. And actually here, can you see that? There's a lot of fat stranding located within this region. And you've got this high density material stuff sitting here. Very, very high density material stuff sitting here. Oh, it's getting even more high density material stuff sitting over here. And actually, can you see that? Look at that. There's a defect there. So what's happened is that this knife has probably gone this way, like that, and gone into the heart. And so this patient's had a punctured ventricle. We've managed to take the scan. in the middle of them, like essentially bleeding out of their heart and into what looks like their sort of diaphragm or the cardiophrenic angle area. And that's actually probably a lot of why there's so much blood seeping down this way. You can see that. Yeah, and then going along the diaphragm like so, and along the edge like this as well. So the next thing to do is just to make sure that there's no evidence of any fractures, because sometimes when someone does get stabbed, you can get fractures, and they've been stabbed around this area. So sometimes you get fractures of the ribs, but I can't see a fracture of the ribs. And essentially as well, because the transverse colon goes across the top like that, sometimes you got to make sure that they don't have a perforation. So let's have a look at the transverse colon. I can't see a perforation for sure. And then you've got to go to lung windows actually to look to see if there's any locules of air within the upper abdomen. So there's no locules of air. So this is not great, is it? This patient's got what looks like a stab wound located within the anterior chest over here, extending through into that ventricle. And the one last thing I'd like to say is actually what you do is also check the lung windows, because sometimes you see plasters in different, so we can see a plaster there, as any plasters anywhere else. And that doesn't look like it. So sometimes that could be a clue to try and find out where another stab wound could be. But anyway, that's a trauma case for you guys, and quite a horrendous trauma, isn't it? Oh yeah, sorry. And one more thing, there's a few more things I'd like to say. So when someone has got a stab wound like that and they're bleeding, you've got to look for hypovolemia. And the way to do that is to make sure that their IVC, is the IVC okay? And that actually looks nice and circular. If it's very flattened, then there's gonna be pancake IVC, which means that they've got low blood volume. The adrenals can get hyper enhanced. You get hyper enhancement of the kidneys. Sometimes you get hyper enhancement of the small bowel as well when it comes to this hypovolemia syndrome situation. But this situation, unfortunately, you've got someone who's been stabbed in the heart. We've managed to catch it in the middle of their bleeding. So anyway, I think we've hit time. Yeah, 6:55. We've gone through some hopefully very interesting case with all very good learning points. Please do give us feedback. One last thing I do want to mention is in a couple of weeks, I will be teaching on a course for Collective Minds Radiology, acute CT body course, so very much in the same vein as what we're doing here, but this is a bit more fun. This is a bit more, we try and keep this a little bit more structured. We go through introductions, approach to CT, protocols, etc., etc. We've got some really great cases. It's been very well received. So if you do feel like come along, we would love to have you. We've got a fair few people. It gets quite popular, so we do try and cut off if we have too many sign-offs. But if you are interested, please do check it out. What I'll do, I'm going to put that link in this description. And Sadul's also put a link in the description for feedback about what we've just done today and the general Collective Minds Radiology and what we're all kind of working towards, which is trying to make a good community of radiologists and radiographers working together and learning from one another. So yeah, as always, thank you so much for joining, and I'm going to hand it back to Sadul, who's my cousin, by the way.
Yeah, well done, Imran. Well done. I mean, everyone who's joined tonight can agree with me. It was a very, very good webinar, as always, pretty much. Keep in mind that all the cases are posted on our global community. So if you would like to look at them, please do so. So all you have to do essentially is just to log into Collective Minds and look at the cases. It should be there. Also, for the next webinar, if you would like Imran to look at your case, make sure that you post it on the global community and tag Imran. So write at Dr. Lasker in order to tag him. That way we can put your case into a case collection for Imran to look at during the webinars. I posted a evaluation form, like Imran said. Please fill that out so we can send out the CPD certificates to you. And that was all for today. I hope that it brought a lot of value to you, because it certainly did for me. And I hope to see you on the next webinar. All right. Okay, everyone. Bye-bye.